Good morning, I'm Dr. Michael Allen. I want to share with you today about spinal pattern generator, what makes a person walk, what makes a person stand up, what makes a person respond to standing up straight when they're walking, and if they get irritation on their feet or if they get some irritation, what makes them take on the posture that they take on. That's a big broad category, but I mostly will aim it toward the quadriceps and hamstrings so that you can get a foundation of where we're going to be working. And then during the workshop, we'll try and put it all together and look at other muscles as well. Walking is very complicated, and I'm not sure that anybody has a full understanding of what makes a person walk or how a person walks. Where are those mechanisms? But instead, it's an integration of whole body function. It's an integration of proprioceptive input, muscle timing, brain coordination, cerebellar afferentation, midbrain responses. Walking is quite complicated. The idea for this spinal pattern generator came to me one day when a patient was on my table. He had such a bad case of sciatica that for 2 months he couldn't find a comfortable way to sleep. He could not sleep a full night, and it was very frustrating to him. I treated him about 20 times, no change in his symptoms, and I was frustrated. So I took my notes and I prayed. And all of a sudden, this picture exploded in my head. It wasn't an idea that I learned in class. It wasn't an idea that I learned in a book. I went home that night and put into the internet every single keyword I could think of, and not much came up, except back in the early 1900s when Dr. Sherrington, father of modern day neurology, was trying to understand a person's walking patterns and where in the cord did this walking mechanism occur. And he couldn't find it. He didn't know enough neurology yet. We still don't know enough neurology. The point is that understanding the gait isn't something you're going to walk away from here having full knowledge of, but I hope it stimulates you to look with patients that come in and try and figure out why the muscles do what they do. In applied kinesiology, we look at individual muscles very often. We look at this muscle test, we look at that muscle test, and we look and see how that muscle's doing. But we don't consider that that muscle may actually have an origin and an insertion that cross more than one joint. And they work differently when they cross more than one joint as opposed to those muscles just cross one joint. So we have to understand biarticular and multiarticular muscle function in order to get a real understanding on how these muscles work. And a patient of mine said it very well. He said that most of the time you go see applied kinesiologist and they just squeegee muscles. You know what he means by squeegeeing muscles? You know that thing that you clean the window with, the squeegee? What do you call them here? Squeegee? That he says, you know, you'll rub a reflex here and you'll poke and prod at the muscle trying to get it to be strong. You can get that muscle strong, but is that muscle strong relative to its antagonists? Is it strong relative to its synergists? Is it strong relative to other muscles in what we call a homologous column? A homologous column is when a certain muscle does one thing, there are other muscles that have to help that muscle do that job, and those are pre-programmed in the human system. And when a muscle does a function, there are other muscles that have to quit functioning so that the first one can do its job. Those are homologous columns. And homologous columns exist from head to toe, from the tip of one arm to the tip of the other arm, from front to back. Homologous columns are totally involved in the way this system works. So instead of just working a reflex or giving a nutrient or doing the things that we know so far, we don't want to squeegee muscles anymore. We want to be working on the whole body and make the whole body express itself. That whole body expression is what we're working with applied kinesiology. So we want to explore the whole picture of uni and multi-articular muscles and understand what makes this system work. Like I said, we're going to study the balance between the quadriceps and the hamstrings, and we'll try and observe the coordination of the locomotor system using just those two muscles to try and understand the whole picture, and then we'll put it together. Proximal rectus femoris first. Have them sitting up straight, and their hands can be at their side. You don't want them to use a lot of arm strength in this test because that'll support, it's like doing a dendritic maneuver when you're doing a deep tendon reflex on the patella. You don't find anything, you have a person pull hard, you might find something. This supports the upper neck and causes more afferentation. So if they don't use their arms on this test, you're basically getting a good look at the proximal quadriceps. So hold your knee up, don't let me push straight down, and just push straight down toward the direction of the ground, and that's fine. So everybody do that first. Just check the quadricep with a good degree of strength, each side, one side, then the other. Okay, now you can check the deep tendon reflex. Hold up, don't let me push. And you would expect facilitation because you're checking the quadriceps. So go ahead and do it. Check the deep tendon reflex. Okay. Do the same on the other side. Hold up. Good reflexes. And those are appropriate. Now do it contralaterally. Tap one side, check the other. Hold strong. Very good. Okay. Have the person turn their head to the left. Hold your left leg up. Don't let me push down. You would expect inhibition on the left and facilitation on the right. Turn the head to the right. Hold your right knee up. Don't let me push. You would expect inhibition ipsilaterally and facilitation contralaterally. Okay, this is a tonic neck reflex and the quadricep proximal aspect.
Ipsilateral, we're supposed to expect ipsilateral.
Ipsilateral, strength extensors, weakness flexors.
So here's the general rule. Tonic neck reflexor. With tonic neck reflex, when you turn your head to the left, it causes extension of the, it facilitates extensors on the side toward head rotation and flexors on the side opposite head rotation. This is what should happen. Turn your head the other way, you get the opposite effect. So if you remember one, you'll know the other. I always remember extensors turn on the side opposite head rotation, on the side, I always remember extensors turn on the side toward head rotation, and flexors turn on the opposite side. Okay? So, did you do that? Turn the head, check the muscles. Turn the head the other way, check the muscles. Let's check the lower part of the hamstrings. Don't let me pull. Good. Don't bring your leg up. Hold strong. See, it's important to keep the leg in neutral here. Good. Now turn your head to the left. Hold strong. We would expect facilitation on the side opposite head rotation and inhibition on the side of head rotation. Turn your head the other way. Hold strong. You would expect inhibition of this hamstring ipsilaterally. Try again, don't give up. And you would expect facilitation of the hamstring contralaterally.
Because the lower hamstring is a flexor and not...
Because the lower hamstring is a flexor, correct. Okay, so go ahead and do that. Check the hamstrings.
Let me just test them. And you're expecting head to the left.
This is a flexor muscle. And so you would expect flexor facilitation on the side opposite head rotation.
The flexor should be off on that same side, shouldn't it?
Okay. You can check the lower rectus femoris. I usually put my hand under the person's knee. It's more comfortable for them. And don't let me push. Okay? Same thing, hold strong, don't let me push. Good. Now turn your head to the left, hold strong, don't let me push. What would we expect here? Facilitation, head straight ahead, and to the left again, hold strong. We would expect inhibition, turn your head to the right, hold strong. We would expect facilitation, hold strong. We would expect inhibition. Okay, so do that.
Something works when I turn to the right.
Was that comfortable when I put my hand into there?
Yeah, it was
Yeah.
fine.
Sometimes.
At least something works turning to the right.
That's right.
So you were saying sometimes?
Sometimes if you do this, hold strong. It can get uncomfortable on the table.
Of the knee, so we're testing this as a sensor. Turn your hand to the right, so that should be on. That's an extensor.
That's the same as this one, no?
Yes. And that one. No, take
On the opposite of the
That's correct. Now head to the left. This one should be on.
Good.
tonic neck reflex. The quadriceps, when it first the one going up,
And that should be
should
off.
go weak
On what?
on head rotation.
To which side?
To the same side?
To the left. This is a flexor. It's going to be weak on the same side. Yes.
Weak on the same side. But the lower
Is an extensor.
is an extensor.
That should
Yeah, it's a
facilitate.
knee to extension, yeah. So it should make it strong
Correct.
on the same side.
Correct.
If you're confused, then knows what the driver's going to be like.
Now you can add to that. Let's go another step. Here's a flexor withdrawal response. Hold your leg up. Don't let me push. What would we expect here? What would we expect? If we stroke the sole of the right foot and in the seated posture check the proximal rectus femoris, what would we expect? It should be facilitated. Let's check the other side. Hold up. Don't let me push. That should be facilitated. Try the other side. Hold strong. We would expect what? What would we expect? I stroke the left one and check the right one.
Inhibition.
It should be inhibited. Hold strong. And that should be inhibited. Okay? And it is. Right. So do that. Stroke the sole of the foot and recheck the proximal rectus femoris.
That's good.
That's
good. That's good.
That's good too.
Something works.
Very good. Okay. Here's a twist. Everybody ready for a twist?
No.
Stroke the right hand and check the left rectus femoris. What would you expect?
No idea.
No idea.
Okay.
When you step back, so
Wait.
That should be facilitated.
It should be facilitated, correct. It should be facilitated. It should be facilitated. You step back because you step back with the same side leg. Ouch, and step back with the right. Facilitated here. Stroke this, that should be facilitated. Okay, go through it again. Ouch, push back as protection, and step back. What's happened to the legs? Your right leg is in extension and your left leg is in flexion. So you would expect when you stroke the palm of the right hand for a facilitation of the proximal aspect of the left rectus femoris. Okay, so give it a try.
Stroke the right one
Go.
and test the left.
on the other side.
So you should be on.
You did that one.
That shoulder should be straight.
I did this one.
Yeah, you did that one.
It better work again.
This one should be.
That didn't work.
Hold strong. Yeah, there it is.
Why is it working now?
Hold strong. Good.
Why didn't it work before?
Were you ready? I don't know.
Maybe not.
So do the same thing and check the ipsilateral quadricep. What would you expect? Hold strong. You would expect inhibition, correct? You know what? That's a gait pattern. That's all we're checking is gait. That's all we're checking. This is another way to check gait function. So when a person's walking now, you begin to put together all of the things necessary for a person to walk. They have to have deep tendon reflex, they have to have flexor withdrawal reflex, the tonic neck reflexors have to work. You're going to find that gallant response has to work, cross chord reflexes have to work. This is why we can say that the central pattern generator is not any one place, but it's all of these things mixed together. Oh, but wait, when you get a tonic neck reflex that's on display after 6 months of age, you know what? That's pathological. I'm going to tell you you're full of hot water, because that should be on display. With manual muscle testing, we should be able to find these things and see them display as they're appropriate. Not to see them display because they're inappropriate. Everybody in this room that has a normal reflex at this point would be considered pathological by the old rules. We need to change the rules now. These rules are new rules, and these new rules are what make us uniquely human, and that's what we want to be, is human. We want to have all these systems meshed, intermingled, working together in sync to make the system work. This is a very important point, because the older way of thinking is you have a primitive reflex on display, you've got pathology. You've got a tumor someplace. You've got an upper motor neuron lesion. Well, that teaching is false, because these reflexes have to be meshed and working.
No, we're all weak on the test.
But that's a person who's not working up to their human potential. Okay? All right. Any questions on these? Okay.
Could this actually direct you in terms of therapy?
Absolutely.
Like supposing, we did say the straight leg earlier bilaterally and it was sacral, and then, no, let's say that wasn't there, they were normal, but then sitting, you did it and it was bilateral and you thought sacral. And supposing there wasn't anything else there and you went to the sacrum, if you adjusted them in a supine position as opposed to another way, I mean, could that direct you in terms of positioning?
And there's an excellent way, with your question, there's an excellent way that we can learn what side to put the patient on. If we have a sacral challenge that says adjust the sacrum positive theta y, which means looking from the feet clockwise, okay, then which side do you lie the patient on? You write them on the left side or you lie them on the right side? You got two choices. That means you're going to be wrong half the time, because we want to have the spinal coupling of the lumbar spine being consistent with what spinal coupling is all about. So then you have them turn their head, and I can show you that in just a few minutes. But yes, it can direct therapy. In this case, with a dysfunctional quadriceps, if that's all it was, would I look at the pelvis? Absolutely. But a bilateral quadricep weakness says C2, 3, and 4. I'm sorry, C3, 4, and 5. That I would look to C3, 4, and 5 levels to look for therapy to fix a bilateral quadricep at this point. Hamstring again, I would look at the sacrum. Sure. Okay, any other questions?
If the withdrawal reflex is part of if the withdrawal reflex is part of the gait pattern, if you like that, surely you're in homolateral crawl.
I can see how you would think that.
Yeah. So this is what I would be curious about.
Yes. Okay, so ouch, push, and step back. Is this a homolateral crawl pattern?
Yes.
It looks like it, doesn't it? But this is actually physiologic pattern. It's a physiologic protective pattern. and it's only instantaneous. So you might call it homolateral crawl. It's protective. So it's a different, it's a unique rule right now. Okay? It's not something you do all the time. It's not going to build plasticity into your system so that you become homolateral. It's a protective response.
When we're
But,
testing,
but I'm sorry, let's go back one more thing. Ouch, push, and step back. I've got physiologic extensors on here and physiologic flexors on here. You see that? So it's not really the rule.
when we're looking at a difference between the distal and the proximal muscles of both the hamstring and the quads, when we did the test for the hamstrings, we used glute max, didn't we? Well,
It looked like
it
it.
looked like glute max. So why is if there
You're
was
going to start over.
I'm getting into talk. So when we were looking at earlier the distal part of and the proximal part of the muscles, both the quads and the hamstring, and we did a test which looked like the glute max test.
Talking about when we were lying down
Yeah,
on the stomach.
A while ago, yeah, this morning. Can we not say then that the rectus femoris is going to be antagonist to the glutes and the hamstring's working all the time? Are we sure that it definitely works in two parts? Could you not just say that it turns off the glutes? The hamstrings are still working, that's why the distal part of the hamstring appears strong.
Yeah,
So
you could look at it that way. But the key to looking at it that way is doing the muscle tests that support your thought. And this is good thinking, because this is how I came up with this stuff. I was just looking at the reflexes and thought, well, if that happens in normal, will it happen in my patients? And if it doesn't happen in my patients, can I bring it to the point where it will happen, and does it help the patients? So your question is very good. Try it. Examine it. See how it fits.
but that changes the muscle pattern between agonist and antagonist that we learned at college or whatever.
Right.
It blows out more completely.
It'll change your thinking. It'll change your thinking. Now, we have to be okay about doing that. Well, I already told you about how we changed thinking about primitive reflexes today. Alan Beardall, back in the late 20s, changed thinking about how to check muscles of the feet. In his foot examination test book, he has muscles named that aren't even found in anatomy books. He has examined muscles and looked at the way they pull, and he's renamed muscles that were named a certain way because of the way they perform. And we have to be okay about making up these new rules as long as we can support the fact that physiologically, neurologically, anatomically, that's how they work. You know, that's how they were named in the first place. Maybe there was an error. Maybe we should correct that error. So, good thinking.
Can we have could we have a simulation to understand how you would approach a case with all the reflex being wrong or weak, back and forwards, what you're expecting for station or inhibition, and then you find that it's not working, and have an understanding how you put together, because of course the body is amazing and it's very well organized, it's not disorganized. So for all of us being in the room with all the negative reflex, I'm sure we're not that disorganized, even though we're not perfect. But I would like to see it, if you don't mind.
Oh, I'd be glad to.
So we can go forward, and maybe I'm not the only one thinking that way. So we have an understanding, because it's quite overwhelming, even though we've been to other seminars, so we understand. It's very easy to get lost, but I'm sure the body is amazing and is well organized.
Yeah, true. Be glad to. Other questions before we do that? Okay. I'd like to tell you a story to lead into that. Early on in my professional career, I graduated from chiropractic school in 1977. I took a naturopathic board exam in late 1976, became a naturopath and a chiropractor. I actually became a naturopath before I was a chiropractor, although I graduated from chiropractic school. I did that by challenging the board exam, and then the board changed January 1st, 1977, so in order to get a naturopathic certificate then, you had to go back to 4 more years of school. So it was definitely in my advantage to take the board before I graduated, and I was glad they allowed me to. Anyway, I applied for some disability insurance through an insurance company, and they required a blood test. So I'd be glad to give you the blood. They came back 2 weeks later, and they laughed at me, and they said, "We can't insure you. You're a drug abuser and an alcoholic." I said, "What?" They said, "You're a drug abuser and an alcoholic. We're not going to give you any insurance." I said, "You know what? You couldn't be talking to the wronger person. I've never used any drugs in my life. and I seldom use any alcohol. And they said, well, the GGTP level's too high, and that indicates that you've got these problems. And you know what? I knew that from school, but I knew it didn't fit. My friend Bob, his parents lived behind my parents. I say that because I lived on the through street. He lived in a cul-de-sac. But we always tease him about that. My parents lived in front. Anyway, Bob's dad was a narcotics officer at the Arcadia Police Department, and I knew that if I ever took any drugs and he found me, he'd tell my parents. So it's Mr. Chatwin that I attribute to never taking any drugs. One day Bob came over. I was sitting at my desk studying, had a bottle of niacin sitting next to the lamp, and he said, "What's this?" I said, "Oh, just a B vitamin." "Well, how's it work?" I said, "Take 2 and find out." He took 2 and he sat there for a half hour and nothing happened. Darn. So he left, went out the house and jumped over the wall and went and sat next to his dad to watch a football game. All of a sudden he says, "I got to go back over and see Michael." He ran through the house and came back and, "What did you give me?" Bright red. I laughed at him and I said, "Bob, it's just a B vitamin. It just took too long to work." "Oh, I thought you gave me something. My dad was going to catch me, so I ran over real fast." Bob and I were the only guys in high school that never did any drugs. So getting back to the other story, I went to the University of California, Irvine Medical School library, and I spent 4.5 hours looking through every book I could think of to try and find out how come my GGTP level's too high. And I didn't find anything other than what I knew in school. So I was looking through the book and just strolling, and I came across a diagram that showed how GGTP is related to metabolism of glutathione. Oh, and glutathione metabolism and using a certain B12 coenzyme can help this GGTP level go back into normal. Wow, I'll go find some of the stuff. So I started taking it, a B12 coenzyme, and the numbers plummeted. And so I thought, oh, okay, I'm fixed. Back up again. Took it again, plummeted. I didn't take it, went back up again. Wow, this is really cool. Remember, I'm just brand new in practice. This is the late 70s. So I decided to start looking into this, and patients who are going to be your toughest patients, that's why I'm bringing this up, your toughest patients are going to be the ones that are muscle tested like I did. Everything tests strong. No matter what you're doing, everything's going to be strong. Well, I thought, I'm just a healthy person. No matter what, no muscle test is going to go weak. I touch this reflex, touch this reflex, therapy localized here, there, nothing went weak. But you know what? I didn't feel very good. And I knew there had to be something wrong. Maybe this AK doesn't work. Well, it does work. These patients are going to be your toughest patients. But once you learn these reflexes, you'll be able to get in and make some changes that will cause that cascade effect, and more things will fix themselves and hold, so that eventually with time these people will start to respond properly. But I just want to tell you about those patients, because in the past year I probably had 3, and one of them I went years trying to figure out. Now I can get through them pretty fast. But when you see somebody like that, if you have questions, call me or write me, email me. But there are certain things that you can do, and I'll show you that if we find that person today.